Ladies and gentlemen, I would like to request that we start this meeting. And before we begin, I think I need someone to pray. We can have a short prayer. Can we have a volunteer? Yeah? We pray. Father, come to you this morning. Thank you because you've been with us as we have started this meeting. I pray that you will be with us till the end, Lord Father. All those who are joining us, I pray that you will also bless them with the name, Lord Father, and guide us through to the end of the day. Just in this meeting, so I want to say welcome. Staff who have managed to log in to receive this sensitization program on health issues. This training or sensitization is organized by the Office of the BBC R&D and through the Department of MUHACU is my University HIV/AIDS Control Unit. And in the department, we have 6 staff. That's myself. We have Pauline, Dennis, Dylan, Wilson, and Wilson. In the contract period of 2020-2021, sensitization of staff and areas mainly HIV/AIDS prevention, and the second one will be diseases. We have 2 facilitators who are colleagues who work in the health units. And in short while I will be introducing them. So, we manage issues in the university. It's what we do as a department. Awareness and prevention of HIV/AIDS for staff, students, and also the community. Also, HIV and AIDS related clubs and groups in outreach activities within the university and also beyond. We encourage self-testing and coordinate voluntary counseling and testing services for students, staff, and the community. We also promote mainstreaming of HIV/AIDS teaching, research, and other programs. We work with, of course, with the departments, such as the health units, and others in HIV/AIDS. We also encourage responsible sexual behavior, emphasizing on abstinence before marriage, to staff and students. We also collaborate with the other stakeholders, such as the Ministry of Health and other stakeholders. So that's what we do. Areas. I want to say these people. We have Dr. Paul Bernot is is our acting chief medical officer. He is a dietitian by training, and he has worked in our health unit for over 5 years. So the person presents the topic on diseases. The other facilitator is Mildred. She's a clinical officer in the health unit, and she has many years of working experience in comprehensive units. These are units in the clinic dealing with HIV and TB. So she will take us on the topic HIV/AIDS prevention. She will give an overview of that area. So the one is now asked to listen to the speakers. They will take very long time to take the question to take some 30 short minutes. So we will begin the talk. So we will begin by facilitate and there's a lot of material on this, but I'll try to cover the areas which I think are most important. So a non-communicable disease is a disease that is not transmissible directly from one person to another. With conditions that are often chronic, that is last long or illness for a long time. Occasionally, acute some problems of disability. But there are a few that caused by infectious agents. The agent itself does not transmit easily between one person and the other. So we consider it not directly transmissible. A few of them are parasitic conditions, which we might talk about later. You might know a few, and probably we need to think about those as well. These non-communicable diseases are the leading cause of death globally. You might be aware. Most people think that infectious diseases are the ones killing a lot of people, but actually it is non-communicable diseases. Maybe there is something to be said now that we have COVID, but overall, diseases are the ones causing the most. Cost 68% of all deaths. In 2012, it rose to 68%. In 2000, it was 60% of deaths. So you can see in a few years' time, rise beyond 70%. Majority of people 70. These core risk factors, such as the person's background, lifestyle, environment, increase the likelihood of certain diseases. So every year, at least 5 million people die because of tobacco use, for example, and about 2.8 million die from being overweight. High cholesterol accounts for 6 million deaths and 7.5 million die because of high blood pressure. Something? Okay. Right. Maybe I'm putting it different. So, the categories, actually, there are quite a number, but the major categories are about seven or eight. The first one is respiratory illnesses, for example, asthma. The second one, metabolic conditions, such as obesity. The third, cardiovascular diseases. Hypertension is one of them, heart disease is the other one. And then the fourth is cancer.
followed by mental health conditions. Among the mental health conditions, we include conditions such as epilepsy and others. Then the other one is alcohol and substance abuse and illnesses. And then we have injuries of violence, that is road traffic accidents and other injuries. The other conditions such as blindness, which so you can think of injuries that are smaller but also lead disability. Yes, there's a slide there on various conditions that might be familiar. See, we listed quite a number of them. Conditions. So some of them are hypertension, diabetes, sickle cell disease, mental health, ill health and drug abuse, asthma, violence, as I said, blindness, oral health problems, rheumatic fever and rheumatic disease, coronary artery disease, cerebrovascular disease such as stroke, heart disease, cardiomyopathy and others, cancers, quite a number of them, very many actually. So, to differentiate between transmissible or communicable diseases versus non-communicable, we realize that majority of non-communicable diseases have a gradual onset, might have multiple causes, and have a long natural history. Their treatment is usually prolonged, often lifelong, and the treatment is that most of it is just cure. I think the microphone is off. And care is multidisciplinary. That means not just one kind of health provider will take care of them. It requires prolonged follow-up. And the quality of life will not be the same afterwards once the disease has set in. So communicable diseases, on the other hand, are usually of sudden onset, usually have a single cause, and have a short natural history, short treatment schedule. Cure is often achieved, requires just one single discipline and a short follow-up, and it's expected that the person goes back to normalcy. So I'll talk about risk factors. And these are aspects of personal behavior or lifestyle, or an environmental exposure or a hereditary characteristic that is associated with an increase in occurrence of a particular disease, injury, or other health condition. We have two types of risk factors associated with non-communicable diseases. These are modifiable risk factors. These are the ones that somebody's behavior can alter. And these, the WHO has prioritized the following four: physical inactivity, tobacco use, alcohol use, and healthy diet. Those are really a big deal in terms of causing non-communicable disease. And those that are non-modifiable, those are factors that cannot be reduced or controlled by intervention, for example, age, gender, race, and family history. So those you are born with and you have to live with them. So the older you are, the more likely you are to develop hypertension, for instance. If you are female, then you might have cervical cancer as opposed to a male. Race, if you are black, you are likely to develop hypertension. If you have family history of sickle cell, for instance, then it's likely to occur also in you. Start with obesity because it's one of those conditions that link up with causing very many other chronic conditions or non-communicable diseases. It is one of those public health challenges, and it was a disease of the affluent, that is the West, but now it's creeping into the developing countries. So in the 80s, maybe we talk about Europe and America and other places, but now it is in Asia, it is in Africa. It causes various physical disabilities and psychological problems, and it increases a person's risk of developing a number of other conditions such as heart disease, cancer, diabetes.
the risk of developing more than one of these comorbidities increases with increasing body weight. I have a slide there that describes what we mean by obesity, and we calculate obesity using body mass index, that is the weight in kilograms divided by the square of the height in meters. This is an index that is used. You can always work it out for yourself and know where you range. So the classification starts with underweight. If you are under 18.5, BMI of under 18.5, it used to be 17, but 18.5, you are underweight. The normal range you expected when you are healthy to be between 18.5 and 24.9. You are overweight if you are above a BMI of 25, and pre-obese between 25 and 29.9. You are obese when you are above BMI of 30, plus one obesity is 30 to 34.9, and plus two obesity of 35 to 39.9, obesity class 3 above 40, or BMI of 40. So you can work out your BMI at home just by taking your weight and your height. So as the class go up, that is from obese going to obese class 3, then we know chances of illness, ill health is increasing. And this next slide, you can see people smiling there with a lot of food. And this is eventually, if you make it a habit, you'll end up with obesity. So more than 1.4 billion adults were overweight in 2008. So you can imagine where we are right now. If you are at home sitting because of COVID, you might eat more and exercise less and end up with obesity. So by 2008, that number was 1.4 billion. So now numbers might be higher. Talk about children. Childhood obesity is also a growing problem. We had over 40 million by 2008, so you can imagine how many must be high. And when it starts in childhood, it's likely to flow over into adulthood. And the longer you have it, the more likely to develop cardiovascular disease, diabetes, and other conditions, and death actually. So overweight and obesity are linked to more deaths worldwide than underweight. Underweight was a problem with the developing countries where malnutrition was prevalent, but now obesity is what is killing people. 65% of the world's population live in a country where overweight and obesity kills more people than underweight, as I said. And this includes high-income countries, middle-income, and even the low-income countries. So it contributes up to 44% of diabetes, 23% of heart conditions such as ischemic heart disease, and 7 to 41% of cancers. And that slide shows a healthy lifestyle where people are cycling to school, to work. So this is what is required really of us to minimize obesity. So what is required is supportive environments and community shaping people's choices and preventing obesity. So if we make it a policy and the country encourages that, the university should encourage exercise and avoidance of obesity so that we can only have its full effect where people have access to a healthy lifestyle. And WHO mobilizes the range of stakeholders who have vital roles to play in shaping healthy environments and making healthier diet options affordable and easily accessible. I'll jump this slide here and talk about cardiovascular diseases. These are many, but we know, I'm sure we know quite a number of them. I'm sorry. So some of them, heart attacks, I know most people know about heart attacks. That is the problem there's a clogging of your arteries. The arteries that supply blood to your muscle in the heart. Hypertension is a common problem. peripheral artery disease, rheumatic heart disease, congenital heart disease. Now, rheumatic heart disease is more common in our area, and this is related to some infections, that is sore throat caused by streptococcus. So quite a number of children will suffer sore throat or tonsillitis and such, and much later in life. Heart disease, not very easy to control, so that one we are born with, and if you survive, then you might heart failure is common among those who have obesity, those who have hypertension, and other conditions. Heart attacks and strokes are major killers in all parts of the world. 80% of premature deaths from these causes could be avoided by controlling the main risk factors, such as use of tobacco, unhealthy diet, and physical inactivity. Cardiovascular disease causes more than half of all deaths across the European region, and as well as most developed countries, but it's also coming into our world. 80% of premature disease and stroke is preventable, and you'll see how. So some of the contributing factors are a person's genetic makeup, the foundations of other health are laid early in life, socioeconomic group, mental health, diet, overweight and obesity, inactivity, tobacco, alcohol, diabetes, and so focusing on a combination of risk factors for cardiovascular disease is important. Implementing medical screening for individuals at risk, providing effective and affordable treatment to those who require it. Some of the interventions are fairly cheap and can be implemented even in our systems. So it has been predicted, this is an example, actually two examples, it has been predicted that mortality from coronary heart disease in the UK could be halved by small changes in cardiovascular risk factors. A 1% decrease in cholesterol in the population could lead to 2 to 4% chronic heart disease mortality reduction. 1% reduction in smoking prevalence would lead to 2,000 fewer cardiovascular heart diseases deaths, and a 1% reduction in population diastolic blood pressure could prevent around 1,500 heart diseases deaths each year. 80% of the reduction in the cardiovascular disease mortality in Finland during the period between 72 and 1992 has been explained by a decline in the major risk factors. Similarly, in Ireland, almost half, almost 48.1% of the reduction in cardiovascular mortality rates during 1985 to 2000 among those aged between 25 and 84 years have been attributed to favorable trends in population risk factors. In both countries, the greatest benefits appear to come from reduction in mean cholesterol concentrations, smoking prevalence, and blood pressure levels. So you can see those are modifiable risk factors which can be easily controlled. So treatment, I'll not go into that. What we need to really think about is preventing. Treatment can be a costly affair, long-term affair, so let's prevent. The next one I'll talk about is cancer. This is the uncontrolled growth and spread of cells that arises from a change in one single cell. And the main change can be started by external agents, inherited genetic factors, and can affect almost any part of the body. The transformation from a normal cell into a tumor cell is a multi-stage process where growths often invade surrounding tissue and can metastasize to distant sites. So there are very many types of cancers. Some of them we might know the kind of causes or kind of factors that lead to their development. Some of them we can't really know for now. But for those that we know, we need to take measures to control them. There are things such as physical carcinogens. These are agents that can cause cancer, such as ultraviolet and ionizing radiation or asbestos. So ultraviolet, usually from sunlight, if you are overly exposed, ionizing radiation from X-ray and other asbestos. Now that the use of asbestos has been minimized, but there are still a few exposures for those who have buildings that are roofed with asbestos. There are chemical carcinogens, such as that come from chemicals, and quite a number of them. And there is one particular carcinogen, chemical carcinogen, that is prevalent in our area, and this is aflatoxin. This is a toxin produced by fungus in food, contaminating our food. Arsenic in those who use borehole water, and that has not been tested for heavy metals, so that can also cause cancer. There are biological carcinogens such as infections, for instance, hepatitis B, infections from parasites such as schistosomiasis. Yes. So cancers can occur in all parts of the body, in the pulmonary, lung, breast, colorectal, stomach, liver. And in high-income countries, the leading cause of some of these cancers has been related to being overweight and obese. In low and middle-income countries, cancer levels vary according to the prevailing underlying risks. In sub-Saharan Africa, for example, cervical cancer is the leading cause of cancer death among women. So the other risk factors which we could avoid: tobacco use. Tobacco can cause cancer of the lungs, cancer of the esophagus, trachea, all those structures. Unhealthy diets, insufficient physical activity, harmful use of alcohol, infections such as hepatitis B, which I talked about, radiation, and a variety of environmental and occupational exposures of varying importance. So WHO's approach is prevention is the most important: early detection, screening, treatment, palliative care. So if you may realize, our medical cover right now allows you to have at least one yearly screening for some of these things.
I'll skip the next slide and talk about chronic respiratory diseases. According to the WHO status report of
non-communicable diseases in 2010, smoking is estimated to cause about 71% of all lung cancer deaths, 42% of chronic respiratory diseases worldwide. Of the 6 WHO regions, the highest overall prevalence for smoking in 2008 was estimated to be the European region at nearly 29%. Our prevalence for smoking in Kenya here is smaller, but still it's a habit that can be discouraged. We can do without it. Survey data from 2002 to 2007 indicate that over half of all children aged 13 to 15 years in many countries in the European region are exposed to secondhand smoke at home. And secondhand smoke causes severe respiratory health conditions in children. So if we can avoid, exposing our children to this, it's better. According to the latest available data, over 12% of infant deaths in the world are due to respiratory diseases. Indoor air pollution from biological agents related to damp and mold increases the risk of respiratory disease in children and adults. Children are particularly susceptible to the health effects of damp, which include respiratory disorders such as irritation of the respiratory tract, allergies, and exacerbation of asthma. Damp is often associated with poor housing and social conditions, poor indoor air quality, and inadequate housing regime. Increasing evidence suggests that allergic sensitization can occur before birth and is a precursor to asthma. And ozone pollution can also cause breathing difficulties, can trigger asthma symptoms, cause lung and heart diseases, and is associated with about 21,000 premature deaths per year in 25 countries in the WHO European region.
So that is about respiratory diseases. I'll talk about diabetes, which is becoming quite prevalent. It occurs when the pancreas cannot produce enough insulin to regulate blood sugar. Or alternatively, if you are obese, for instance, the body cannot utilize the insulin appropriately, so you end up with high blood sugar. The overall risk of dying among people with diabetes is at least double the risk of their peers without diabetes. So about 347 million people worldwide have diabetes. That is a big number. There is an emerging global epidemic of diabetes that can be traced back to rapid increase in overweight, obesity, and physical inactivity. And it is predicted to be the 7th leading cause of death worldwide by 2030. So you see where we are heading. Total deaths from diabetes are projected to rise by more than 50% in the next 10 years. So 80% of diabetes deaths occur in low and middle income countries for obvious reasons that they don't have access to screening, testing, follow-up, treatment. In developed countries, most people with diabetes above the age of retirement, whereas in developing countries, those most frequently affected are aged between 35 and 64. These are people still at work. And it causes all manner of complications in various systems, and I'll not go into those, but one or two of them, that is diabetic retinopathy with eventual blindness, damage to the kidneys with eventual need for treatment for chronic renal disease, and neuropathy, which can lead to ulcers and wounds on the feet or on the legs, leading to amputations. And once you are amputated, your level of disabilities really has increased. So prevention, we want to encourage people to achieve and maintain healthy body weight, be physically active, at least 30 minutes of regular, moderate intensity activity on most days. Even walking, just walking is adequate. And early diagnosis can be accomplished through relatively inexpensive blood testing. You realize it's random blood sugar, you get a prick and you know what your sugar level is. Treatment of diabetes involves lowering blood sugar and levels of other known risk factors that damage blood vessels. Tobacco cessation is also important to avoid complications. So I'll skip over this one and go to chronic kidney disease. This is progressive reversible loss of kidney function, defined as either presence of kidney damage with pathological abnormalities and reducing glomerular filtration rate. And there is a chart there demonstrating, at what level you get complications. So you start from an normal kidney, and then there is increased risk such as obesity, diabetes, hypertension. Then you cause damage to the kidney. Your ability to filter out toxins from your blood reduces over time. Eventually, your kidney fails, and you could end up in death if you don't get proper treatment. So treatment, including dialysis and transplant, are very expensive affairs and will drain a family of resources. It is one of the leading causes, diabetes and hypertension, as I said. These are some of the other risk factors: cardiovascular disease, obesity, metabolic syndrome, age and race. I said black people are likely to develop kidney disease more, hypertension more, and the older you are, the more likely you are to develop kidney disease. And malignancies can also, come in play: HIV, hepatitis C, autoimmune diseases such as SLE, and medications such as aspirin and such. The next one is alcohol. This is a big one, and I know we have problems with this. I won't go through the first slide. It's just an introduction of where the word alcohol comes from. Apparently it's Arabic, and in Arabia people don't drink alcohol anymore, so maybe they knew something that we didn't know. So is alcohol a friend or a foe? So
There's been, discussions and suggestions that moderate consumption is useful, but really, that is opening Pandora's box. So maybe avoiding it completely is the best policy. So high levels of alcohol consumption can lead to physical illness, psychological and social distress. Small regular amounts, they used to be seen to have a positive effect on the heart and circulation, but research is ongoing, and most of it suggests that this might not be the case. Increasing use of alcohol along with other drugs of abuse is a serious public health problem across all age ranges, but especially so in the young. So you realize for us, we start using alcohol very early, and by maybe mid-20s, then you are around the point of dependence on alcohol. So there are a few features which suggest that you are dependent. If you are drinking, it becomes a priority over other activities. It becomes a compulsion. You have to do it. Tolerance develops. You have to take more to get to achieve the desired effect. Then you know you are dependent. It can remain neglected for many years because most of us will deny and tell our relatives that we are okay when actually we are not. So there are some signs. As alcohol levels increase with more drinking, there is poor control of muscles, poor coordination, double vision, flashing, bloodshot eyes, and vomiting. And behavior can vary depending on the individual. So we need to be able to, we need to be able to know that it can be variable for different people. So withdrawal occurs when a physiologically dependent person abruptly stops using alcohol. So you develop withdrawal symptoms such as, tremors and sweating, lack of sleep, nausea, vomiting, illusions, hallucinations, anxiety, and others, seizures also. So there is a questionnaire you could use to gauge yourself to know whether you are getting into trouble with alcohol. And so some of these questions, have you thought that you could cut down on your drinking? That is, are you able to cut down on your drinking? Did you feel annoyed by others criticizing your drinking? Do you feel bad or guilty about your drinking? Have you had a drink first thing in the morning to steady your nerves or get rid of a hangover? So if you can answer those ones and you have at least a yes for 2 of them, then you know you need treatment. So alcohol causes various problems. Depression is one of them. Damage to the liver, that is liver cirrhosis, heart failure, damage to the brain and nervous system. So we want to avoid this. This is the other slide about alcohol in the body. I'll not go into that. It can cause sudden death because you are likely to get into accidents, you are likely to fight, you are likely to get injured in other ways. And mental health and alcoholism are interlinked. The more you are into alcohol, the more likely you are to develop mental health problems. Treatment is available, especially for us now that we have NHIF. You get assessment in various clinics, and NHIF will pay the full cost of rehabilitation for 3 months. That is once in a year. They'll not pay if you are going there for the second time. The other one is about drug abuse. There are very many drugs that people abuse, very many substances. Some of these substances are meant to be useful medications and useful items to be used, but people abuse them. And these are linked to mental health problems, problems with injuries, problems with violence as well. So as a summary, non-communicable diseases, it leads to about 30% of people dying from non-communicable disease are in low and middle income countries and are aged below 70, not 60 years. The prevalence is rising rapidly and is projected to cause almost 3/4 as many deaths as communicable diseases. In most middle and high-income countries, non-communicable diseases were responsible for more deaths than all other causes of death combined. And some of the things that we need to think about is common preventable risk factors underlie most of this. As you heard from my talk, there are common features of most of these conditions. And the leading risk factor globally for mortality is raised blood pressure, which can arise from obesity and cardiovascular diseases, followed by tobacco use, raised blood glucose levels, physical inactivity, overweight, and obesity. So millions of deaths can be prevented by stronger implementation of measures that exist today. These include policies that promote government-wide action against non-communicable diseases. These are stronger anti-tobacco controls, promoting healthier diets, physical activity, reducing harmful use of alcohol, along with improving people's access to essential health. So some of these measures you might realize are fairly strong. This season we have the World Rally Championship, and for those of us who are old enough, we remember this was a season when tobacco was being advertised heavily, but you can see right now no one is talking about tobacco anymore. So that last slide is a summary of what is expected of us to avoid most of these non-communicable diseases. Exercise regularly, eat healthy life, reduce stress, and plenty of water. So all these link up to a healthy life. So think about it. Take a walk at least once a day for half an hour, or if you have access to a gym or any other place to exercise, then do it. Eating healthy is fairly simple for us because most of our food is fresh, unlike in developed countries where most of their food is processed. So eating healthy is selecting the kind of foods that you know will not cause you obesity and will digest adequately, not over processed foods. Reducing stress, building relationships at work so that you are able to work comfortably without, having conflict at work and at home, and drinking plenty of water, not alcohol, water. So that is the end of my presentation. There are many areas that I have not covered because of time, but there are many conditions that we could discuss. Some of them include, blindness, things like epilepsy, which are conditions that are chronic and fairly challenging. But what we've discussed here are those that we can modify the risk factors to reduce the impact on our lives and improve our general health. Thank you very much. I'll invite, if there are any questions on the chat, maybe I can take them as my colleague is preparing to take over. Thank you.
Thank you, Dr. Binat. I think that was a good one, according to me. And I've picked some few areas which maybe I didn't know, and I hope my colleagues have also picked something. Yeah, so before we go to the next session, if we have, you can side chats. I think in the system, you can side chats and ask some questions. Is there any question for Dr. Binat? Okay, I think. Okay, I'm receiving some proposal. We'll do it after our second presentation. So I want to welcome Madam Karibu.
Good morning, everyone. I'm going to take you through an overview of HIV with the emphasis on prevention, to be precise, pre-exposure prophylaxis. So just to start us up, I think we all know the definition of HIV or HIV in full. It stands for human immunodeficiency virus, and it is an RNA virus. And some important facts that we need to know is that HIV is still spreading, I would say rapidly, especially now with COVID. And so far, there is no cure or vaccine. The use of ARVs or antiretroviral drugs can prolong and improve the quality of life, but they will not cure. HIV affects everyone in one way or another. We are either affected or infected. And HIV is always contracted, or almost always contracted through sexual intercourse. As much as we have other modes of transmission, that is the most common. But most of all, HIV can be prevented. So it's very important that we are able to take the initiative to know our status. And when should we get tested? It is important to have to know your status, because it will help in decision making. And testing yourself for HIV is very key in your relationship, in your life, and even in your future, because it determines how you will be able to go about your future. And something else that is of importance is when to get tested for HIV. One is, for as long as you're indulging in sex, and when we talk about sex, it's we are talking about vaginal, oral, and anal sex with multiple sexual partners, sex with someone who is HIV positive or whose HIV status you do not know, sex between a man and another man, using illegal injected drugs or steroids, sharing needles or syringes, exchanging sex for money, we call it transactional sex. If you have a diagnosis or treatment for hepatitis, tuberculosis, or sexually transmitted diseases like syphilis, it's important to get a test for HIV. Currently, what the Ministry of Health is encouraging is for us to use the self-test kit. And the self-test kits are available commercially in designated chemists. I believe if you inquire, like here in Eldoret, we have quite a number. I'm told the price is around 800, thereabouts, to 1,500. And it's now a personal responsibility to know your status. So the self-test kit is very good, because you can purchase one for your partner, and you're able to have the testing at your own convenience. You don't have to visit a facility. And so it's also important to know how to use the self-test kit. And once you purchase it's called the OraQuick. It has a pamphlet with instructions on how to use the self-test kit. But basically, it has a swab, and you get the presumed antibodies from the upper jaw. So the swab is swabbed on the mouth, on the upper jaw, and in the lower jaw. And it is dipped in some fluid. And then you wait for 20 minutes, and you read the results. The instructions are very clear in the insert that is in the OraQuick testing kit. And should one test positive using the OraQuick, that is when we now visit a health facility to confirm. So besides that, we also have other modes of prevention. And today I want to specifically emphasize on the pre-exposure prophylactic medication that is now in use. It was rolled out way back in 2015, and it's very important because I believe we all know that HIV is a social disease, and in one way or another, it is very important for us to prevent ourselves. And maybe before we go to the pre-exposure prophylaxis, maybe I would just give you a few estimates, the current estimates of HIV within our county, that's Uasin Gishu County, and the prevalence rates of the age between 15 to 49 is 3.9%. For the males, it is 3.3%, and for the females, it is 5.5%. And with that, you realize that, again, the females are almost always more at risk than the males. And most especially the young adults. When we talk about Pmtct coverage, it's at 71%. Pmtct is prevention of mother-to-child transmission. And this is done when a mother knows that they have conceived, they should visit a health facility so that part of what will be done is screening for HIV. And should this mother be HIV positive, then they are started on ARVs immediately to reduce the viral load so that the baby is prevented from getting HIV. The mother-to-child transmission rates currently within our county is at 12.4%, and that needs to come down more. I believe as the coverage increases, because the target is above 90%, if not 95%, then the rates of mother-to-child transmission should also be of a better percentage. It is also part of prevention because when a mother gets to know their status, they are almost always sure because of the interventions that are now currently in place, they will prevent the child, and the health of the child will be much better, and the burden to the parents will also be reduced, because it's really difficult sometimes to ensure that a HIV positive child gets treatment. As you can see, you will also note that the ART coverage within Uasin Gishu County for the adults is 100%. When we talk about 100%, we mean that all adults who are HIV positive are now getting ARVs. But for the children, it is at 79%. And this is because of stigma and many other issues surrounding ensuring that a minor is taken to a facility for care. So Pmtct is very, very important, because if we prevent the children from getting HIV, then, as I said, the burden for care will be reduced. So something else to highlight concerning prevention is on the timely use of the ART. Once one has been tested, what is currently being done is that once you're tested, you're treated. It's not like before that there is a period or a gap that is left for counseling and all that. Everything is done at almost the same time. Once one has been confirmed to be HIV positive, then treatment starts immediately. It is a preventive thing because the viral load is reduced. So if one is HIV positive and the viral load is reduced, they are able to live a healthier life, but most especially, they are likely or less likely to transmit the virus to another person. Having said that, today, as I said, we would focus on PrEP, and PrEP is pre-exposure prophylaxis. This is the use of ARV medication to prevent HIV infection by an infected person at substantial ongoing risk of acquiring HIV infection. I'll come again. It is the use of ARV medication to prevent HIV infection by an infected person at substantial ongoing risk of acquiring HIV infection. What it means is with sufficient antiretroviral medication, concentration in the bloodstream and tissues, HIV is unable to establish infection. So if one knows that they are at an ongoing risk of contracting the virus, then it's better to be given the ARVs. I'll skip on the background because I've already given the current estimates of the HIV. And what we need to understand is when we talk about prevention, we have the combination prevention, which is behavioral interventions and then structural interventions. And when we talk about behavioral, as I said earlier, HIV is a social disease. So we encourage safer sex choices and behaviors such as risk reduction counseling. That is done when you visit a facility and you want to know your status. You'll be taken through the post-test counseling, the testing counseling, and then after you've been tested, you are also counseled on risk reduction. Then we have sexuality education and social marketing to promote effective condom use. And I believe that is what MUHACU is emphasizing on, and it should be their key role. When we talk about the structural interventions, these are interventions that promote an enabling environment that is protecting the rights of people living with HIV, stigma reduction, because stigma is very key in preventing HIV. If we stigmatize those who are HIV positive, or we have policies that do not support stigma reduction, they are likely to transmit the disease because they'll be shy to come out clearly and even seek treatment. We also have gender-based violence prevention and mitigation. You realize that culturally, sometimes we are predisposed to incidences in families that sometimes we don't really see to it that it is gender-based violence, but in real sense it is. So it's important for us to acquire knowledge on what gender-based violence is so that we are able to prevent HIV. We also have intimate partner violence, where we have couples having differences, and as a result of that, there is also the element of forceful sex. That also predisposes many to also getting HIV. So it is important to ensure that we have balanced families so that even the sex life can be healthy. We also have biomedical interventions, and I had mentioned some earlier, talking about the treatment of STI. When STIs are treated, then the chances to transmit HIV is reduced. We also have PEP. PEP is Post Exposure Prophylaxis. It has been a very common thing, especially within the university, for people to access the service for PEP, especially at our health services. And PEP, we are talking about should anyone involve themselves in a highly risky behavior that would make them feel that they are exposed to the virus, then they need to visit a health facility so that they can be administered to the ARVs to prevent the virus before 72 hours are over. But we are moving away from PEP and encouraging pre-exposure prophylaxis because it is more effective than even the PEP. Then another mode of biomedical intervention is voluntary male medical circumcision. We also offer that at the health services. We know from research that circumcision reduces the chances of transmitting HIV by 60%. And so it is very important to have the males circumcised. And then I had talked about treatment as a mode of prevention, where we have the test and treat. And today we'll now emphasize on PrEP. So I'll skip this slide on the rollout of PrEP because it's not very important. And we will talk about pre versus post-exposure prophylaxis. Why is pre-exposure more effective than the post-exposure prophylaxis? After exposure to HIV infection, it is likely to be established. And so the post-exposure prophylaxis is initiated soon after the exposure to reduce the chance of infection. So for the post, there is the exposure first. But for the pre-exposure prophylaxis, you begin treatment early because already you know that you are at a substantial ongoing risk of getting the virus. So it is initiated 7 days before. So it is more effective in that it will not even allow the virus to be established. So pre-exposure prophylaxis works. It has been shown to work in rigorous clinical trials and also in the demonstration of the real world. Many times, those who have been put on pre-exposure medications have continued to test negative. We've not heard of incidences where somebody turns positive after they were put on the pre-exposure medications. But the effectiveness is also dependent on adherence, because these are ARVs that one has to take correctly and consistently. So virtually no infections have occurred, as I have said. I think the drug choice is not of importance. What is most important is once you are able to ascertain that you are in an ongoing substantial risk, just visit the health facility, our health services here. We offer the service, and you will be assessed accordingly and be issued with the ARVs. So who is a candidate for PrEP? PrEP is not for everyone, but it may be suitable for particular people. And some of these people include the discordant couples. When we talk about discordant couples, we mean one of the spouse is HIV positive while the other is negative. So should one find themselves in such a situation, then the person who is negative is supposed to be put on ARVs. Then we also have people who have sex with someone of unknown HIV status. You're not sure of the sexual partner. Then it is important to also be on the PrEP because you are likely to risk and get the virus. And before you even start using PrEP, you must know your status because PrEP is used by those who are HIV negative. We also have the people who inject drugs. And those people who inject drugs or who are abusing drugs, but more specifically using the injection, they are likely to share the needles and the syringes that they use. So they are at an ongoing substantial risk, and they should be on PrEP. We also have people who have males who have sex with males. They are also at a substantial risk of contracting HIV. And so we encourage them to visit the facility so that they can also get care. PrEP is safe. As I said, studies have been done, and the medications that are recommended are safe to be used by those who are HIV negative over a period of time. And as these medications are administered, we have follow-up to be able to ensure that the side effects are minimal, but most especially that adherence is emphasized. When I talk about adherence, I mean the proper use of the ARVs and the timely use, because it's only by being consistent that the ARVs will work. So they are safe, and people should not shy off from getting the medications. We have them, and we have staff who are in the CCC that are able to assist us to even get the ARVs. We also emphasize, when we talk about prevention, we emphasize on condom use, consistent and correct use of the condoms. And It's very important in prevention of HIV as well as STIs. And even for the discordant couples, we still emphasize on condom use despite the fact that we administer the PrEP. So condoms are available also at the health services. And I believe MUHACU, in collaboration with one of the student clubs, have been very instrumental in ensuring that we get adequate supplies in the designated areas. I think I'll end my presentation there. Thank you very much.
Yeah. My request to the two facilitators has been, I think they took note of it, and we've taken, 30. I was also, looking at my time. So thank you very much for the two presentations. And three questions. You can chat, side chat, or hakuna maswali. Yeah, meanwhile, Dr. Benato saying he can talk something about COVID while we're waiting for questions.
Good morning once again. We are in the season of COVID since last year in March, and we might have taken it that things have calmed down, but as we speak, there's a new wave, and this wave is even more deadly than the previous ones. You must have heard about something called the Delta variant that originated from India. Now, the Delta variant is easily transmissible and causes more severe symptoms. And it might have come to Kisumu sometime last month. Now it has spread quite significantly in Western Kenya. And we all know that there was a new directive from Ministry of Health on 17th on restrictions or further measures for 13 counties of Western Kenya. So among those counties, we know all of the counties of the former Western Province, Nyanza, parts of Rift Valley. So I'd like to encourage our staff and students not to travel to those areas right now because transmission is going on and it's very high. The numbers, being reported daily from those areas are very high. Further to that is that last month, the number of staff and students who tested positive was the lowest since we started having cases. We had about two or three people who tested positive. But this month, we are heading towards a record. And by last week, we had 6 members of staff and 1 student. But right now, I think it is spreading heavily in main campus. Previously, it has been College of Health Sciences and Annex, but right now it's in main campus. So be very cautious, ensure everybody going to a physical meeting has a mask and is using it appropriately. We have students who have chosen to stay in their rooms and refuse to come to be assessed. So be very cautious because these are people walking around amongst us, and we know for sure that if we were to test them, they would be positive. We were lucky to have a few students present themselves to us, and some of them have tested positive as we speak. They are isolating, but they know a good number of their friends who are walking around, and might be spreading the disease within main campus. We also have staff from main campus who are sick and have been asked to isolate at home. And we have a few people who were in hospital last week. We have a few more still in hospital as we speak. It is a deadly illness. The vaccination might have helped a little bit, but still, we don't want to acquire this illness. Please take the precautions that we've laid in place and ensure that you protect yourself. For those who are waiting for their second dose of vaccine, then I'd like to inform you that the vaccine is now available in SS Health Center, Chepkigen Health Center. It's also available in all the health facilities of Uasin Gishu County and some private facilities like Eldoret Hospital Room 206. So you can confidently visit those places and get your second dose. MTRH will be giving the vaccine next week from Tuesday for our staff in College of Health Sciences. Once you get your second dose, keep practicing the safety precautions because you still want to avoid infection. Thank you very much.
We have a question on PrEP, and somebody is asking what will happen if you use PrEP and you're HIV positive. You definitely cannot use the PrEP if you're HIV positive because part of the assessment that we do is testing. PrEP is for those who are HIV negative. And should you be assessed and you're HIV positive, then you're started on ARVs immediately. Thank you.
Thank you. Any other? Hey, colleagues, I need one question. One is not enough. Is there? Yeah? You can use the mic.
Thank you so much. In the previous past, we've had research. We've had research about HIV and AIDS, and there are some areas which have had a higher rate of transmission, such as, can you show an example? Western and Nyanza. Why do you think those areas are topping the list in terms of transmission? And what is it that can be done in order to reduce such?
Thank you. I think, Minister, those are very good questions.
The incidences of HIV or the prevalence of HIV has been high around the western part of Kenya. And previous research has shown it may be as a result of the circumcision. Some communities that live in the western region don't practice circumcision. And that is how the voluntary male medical circumcision was started. And I believe with the much sensitization that has been done, the communities have continued over time to accept the circumcision. And another thing is just lifestyle that will take time. HIV is a social disease. And we talked about behavioral prevention, which we need to continue to emphasize. It's very key as an individual to just purpose, irrespective of the community you come from, to prevent HIV. Thank you.
If I may add, there are some cultural practices also in play, and I think the message has been relayed that some of these practices are not really necessary and can be avoided. There are some, issues with beliefs in those areas. Initially, people thought that HIV was witchcraft and other issues like that. So most people would remain at home taking herbs, not getting treatment and transmitting HIV. So that is one. The other one is there are some cultural issues that have been flagged really. Commercial sex work. These are transit points between Kenya and Uganda, and commercial sex is prevalent. There is inheritance of wives and such other cultural issues, which I think people have learned over time to avoid. And it's not just Western and Nyanza. You realize at some point the coast was also highly prevalent, Nairobi, So we need to look beyond just that area and know what it is that is on the ground that people are doing, leading to increased transmission. We need to also say that areas such as this, the locality within which the university is, can be a hotspot because there are people from various areas. It's cosmopolitan, yes. We have young people who take a lot of alcohol, take drugs, inject drugs. There is commercial sex. All those things are going on. So we need to be cautious and, to relay to everybody that prevention is better. We don't want people getting infected anymore. We don't want people dying from HIV. So it is not a condition for which people should die at this time. Thank you.
Thank you. Listen, and the questions have been answered. I have one question saying forums such as this for our students, either physically or virtually. I can vote. With this year, this 2020-21, we didn't have forums for students. But the previous year, we were going around to schools. I remember we took our facilitators. We were timing when they were having common courses, common lectures. We went to do some very short sensitization on HIV. So what we will do, I think we will record. I know this training or this meeting is recorded. We will organize with our colleagues from PRO's office. We will put on our web so that people can read for themselves. Yeah, thank you. I think we have enough questions. Are there any more? Have you seen any? No. Yeah, I think we've taken about 10 minutes or 15 minutes. And finally, I want to close this meeting. And before I close, I want to say, or I want to thank most sincerely our colleagues from the health unit. I think the areas they have covered, I think they've covered exhaustively. For more information, I think we'll also have, if you're interested, if we can leave an email. I know we have this soft copies. If you want, we can give. Okay. So finally, I want to thank all the members or all the staff who have managed to listen to this training. I think it was very, very good to me. We want to share information. Our institution is an academic institution, and I would encourage our colleagues in academic, like in social sciences. I know a lot of research has been done in the College of Health Sciences on some of these areas. And I would encourage even our colleagues in social sciences. They are very good, these are very good areas where we can do research and disseminate our findings to our students, to the community, and beyond. So I want to say thank you, ICT, our PRO's office, the members who are here, my colleagues from the department. I've seen a colleague from Extension. I want to appreciate everyone. I think I want to close this meeting, and I request, I think we had our pastor can close. Thank you, and thank you very much.
Thank you for the best word on HIV and PrEP talk and all the other diseases and how to deal with them. So we're gonna close our eyes and pray. God, is another moment to come unto you and thank you for the success of this meeting. I pray that you may be with us and that you may enable us to feed in everything that has been talked through in this meeting. In Jesus' name I do believe and pray. Amen.
Thank you.